that gave rise to a bilirubin of around 30, and here bilirubin settled over time and came back to normal. Now the trouble is that we see a lot of stricturing and dilatation. If you can follow me to the intrahepatic, high up, you see yet a dilated main, maybe right hepatic duct.
Can you see the radiology image in a bigger screen, please?
Radiology, keep it running. You see that there are a lot of strictures and dilatations, and this is really extremely suggestive of sclerosing cholangitis. If you just follow segment 7 or 8, they're what is going up.
Can you enlarge the radiology image? Yeah, excellent.
Okay. Can you follow me?
Yes.
So I am moving around here with my sphincterotomy in, yet having no idea how can we help the lady. But the feature is maybe that of sclerosing. That's what I can tell you. We don't like to fill here much with dye because there will be no...
there is some bleeding.
The drain is a little bit altered. An MRCP could have helped here already in planning her ERCP. But apparently, as you see, we will give a little bit short dye here. We are a little bit low down with the sphincterotomy. And you follow with me, and this segment from the tip of the sphincterotomy to maybe, this is a segment of maybe 4 or 5 centimeters, is a little bit narrowed. And this might be the side where the gallbladder have been in contact with the, or the inflammatory mass with the CVD. Okay? Well, I can, at the end, oh yeah, we are lost here. So it's extremely difficult to fix, you see, we are lost. Anyhow, so it's okay. So there is no, we will move here a little to give you a better idea. We are near to finish. Renal X-ray. It's okay, but we cannot help her anymore. So you see this.
Is this clad skin or what is this?
No. Now the dye is mostly out. And what is inside is just the guide wire. Because we are by far out, the scope is already in her stomach, it's slided out. And this, where the guide wire has been, is the side of the little bit narrowed segment of the CBD. Okay? I will try to go back again to make things clear. I think she has been exposed to surgery repeatedly, and the surgeon is convinced, and she's draining nicely bile here. And the surgeon has already inspected all the area, and the histopathologist confirmed the absence of growth.
And the liver was free.
Okay, and the liver has been free, as I hear. The tumor markers are normal, and she returned back to normal. Okay. Now, alkaline phosphatase is high, Sharon.
Within normal limit.
Now, everything is within normal limit. So, if you have any suggestion, you tell me, because my advice is just to keep her in peace, okay, and see if she's improving further, then well and good, and if she relapses, then we may tackle her again.
Liver biopsy is not indicated.
Liver biopsy, because of the normal panel, liver panel, there will be no indication. ورينا مرة ثانية, go with the wire inside. So we are inside here again, and I just will show you that little bit, you know, if you grade, you will lose it. So go with the wire deep inside. And that side where we thought it might be stricture, you see the wire goes with ease inside, and now we will inject more dye, and you follow with me. So just the probably partially narrowed segment. You see it going high up, but you know the caliber is not less than 5 or 6 millimeters, and it should be all right. What is up, what is dilated up, this is not explained, by the way.
It could have a significant stricture distal to that dilatation.
Well, you see, if we grade, we will lose here. Huh?
But honestly speaking, we have.
But you know, if she has got, Yeah, then she should have been at least, she should at least have a raised alkaline phosphatase, or alkaline phos, or, you know, or a bilirubin. Her enzymes are extremely normal. We don't know if she will not be helped by a sphincterotomy. It will be useless, because and there will be no place for a stent, you know, because there is nothing to stent here, because the residual CBD is quite patent. And so if you have any suggestion, you tell me. Otherwise, I will keep her in bees. Huh? The audience? So apparently, this is not a Meritzi. Then there have been no stone at all, or a very small stone in the gallbladder. Okay? And there have been inflammatory mass, and
that was, we couldn't find explanation for the
yeah, for the mass.
Trying to push a wire in that dilated segment.
Which one? What are the common hepatic and the intrahepatics are all dilated. Okay, and the dilatation is rather maybe due to the relative. So the guide wire has been anyhow quite high up. The only thing is to try to dilate that segment, but you know the dilator has got a diameter of 6 millimeters. If you dilate high up, you should not dilate more than 6 millimeters. So go in with the guide wire. So this is the way to do it. اي لكن هو هي more than 6 millimeters. look شو بدير من dilatation. بس لا في شيء. So the guide wire can be give شوية dye معلش مرة ثانية هاي. So we'll give more dye here. But you will see now this proximal CBD segment is nicely visualized.
Enlarge the
And it's
X-ray
okay,
image,
no?
please.
Sorry?
Enlarge the X-ray image.
Enlarge? How can I enlarge? There, with you, not with me.
من احنا خلاص
Okay, ask please Mr. Faraon, he will do it.
Mr. فرعون.
I think we will keep her in peace, okay? After all this nice recovery, I don't know. Any suggestion from there? Huh?
Prof. Abdul Fattah,
wait and see.
do you recommend for the auto-antibody study for this patient, smooth muscle antibody and anti-nuclear antibody or anti-mitochondrial antibody?
Yeah, you know, you mean an immunological screen?
Yeah.
You know, an immunological screen will not help much here, because at this level here, ERCB should be normal. Okay? But this ERCB is not normal, by the way. You know, it's not normal because the intrahepatics are almost dilated. Some of them are really saccular there, if you see. That might be segment 4, which is coming high up. That's really already a gallbladder-like. So it's a dilated biliary system. There is evidence of beading, well, not in all, because, you know, segment 6, which comes down towards the scope, is not beading. But, you know, bead should not be through all, you know. You may get it in a random fashion, and you may get it localized in few of them. And if this is really beading at segment 4, then you should there go with a brush.
Can this be a Caroli's?
Yeah, or you should go with a brush biopsy,
Can this
and
be
brush this area.
Can this be a Caroli's syndrome?
Well, Caroli at this age, you know, it's very unlikely. They should not have missed it. You know, the ERCB itself does not suggest this. Then we have got only one saccular dilation there. You see nicely here, really, we may review the X-rays later on. there is evidence of bleeding, no doubt. The right hepatic, this might be 5 and 7 and 8, you know, are classically bleeding. But yet I am not so sure. Nonetheless, she should have an MRCP maybe, okay, and she should have a tight follow-up, maybe, okay. Nonetheless, we would like to review her maybe together in 3 months' time or so, okay? If you can call for her here with you or with us, it doesn't matter much. But we should stop here.
Okay.
Starting also, there is a big trouble because we don't have really a serological marker. We have got nothing. All her investigations are now within normal, and we should keep her under follow-up. This is our right because of that picture. And if she shows, she will show further. You know, the drain is quite nice. So, and there is really here, there is no need for any interventional measure in the form of sphincterotomy or what. I think we will go out, if you agree with me.
Okay.
And meet at the last case here.
Thank you, Prof.
Before
Sha'ban.
lunch, okay? Thank you. Thank you.
We will probably move to the second room if there is any patients now. Dr. Bani and Dr. Mistiri.
ترى وريها لي بالاكسري ترى.
Dr. Bani.
اسمع لازم تاخذهم الافلام هذا راه. تبان وكانها
Dr. Mistiri, do you have any cases?
تبان كانها